be able to share my screen. Thank you guys for the opportunity to share. It's nice to be able to sort of, in quotes, be in the same place and see each other. But Evan and I were just discussing that, Zoom and these telechats has really given us the chance to really sort of widen our perspective of folks that are in the field. And so thank you for the opportunity to sort of be in New York with you, even though I'm actually in sunny South Carolina. We're gonna have a interesting talk today about innovation in the context of transplantation and surgery, but it really pertains to, make sure we can all see this. It really pertains to all aspects of care. Now, Evan, if you wouldn't mind, can you confirm that you're seeing that in presenter view there?
Yep, everything looks great. Thank you.
Perfect. I've called this talk a number of different things. I refer to it generally as rejecting the status quo, but it really is a discussion about innovation, which we'll go on to define and then discuss in the context of what it is that we do every day. And then I'm going to end with a call to action for the docs on the phone and those subject matter experts that I think really have a growing commitment to this space. We're going to talk a little bit about surgery, drones, of all things, digital transformation, and more. As described, I'm a transplant surgeon at the Medical University of South Carolina. I've been here for about a year, very fortunate to contribute to our kidney and pancreas transplant program, as well as liver. I'm passionate about what I do, but I do have some disclosures, as are shown on this slide. I get paid to do transplants. I think that's probably worth mentioning. I'm passionate about the field and the science. I have research funding from a number of different folks over the years. Founded several companies, which include a transplant logistics informatics company, which then spun out into two companies around unmanned aircraft, as well as IT platforms in the transplant and beyond space. And then subsequently I have a role as medical advisor for some digital health startups. I grew up in DC, that's what you see upper left. And then I went to medical school, lower left, in Baltimore. And that picture makes Baltimore look pretty good, doesn't it, Evan? I did my transplant immunology fellowship in Boston, and then subsequently my transplant fellowship training at the University of Wisconsin in Madison, which is shown here on this Smiths in Madison. And but now I live here, which is awesome. This is South Carolina. It's sunny, it's beautiful, and I would be happy to buy a beer for anybody who wants to come down. I completely have redone this agenda. At the end of the day, I'm a frustrated surgeon or doctor who wants to make our system better. And my goal today, and I've sort of written and then rewritten this several times, is to just talk about problems and then tell a story about how I perhaps not very efficiently addressed some of those problems, and then to talk about how we can generalize the learnings to non-surgical or perhaps non-subject specific areas, and then to suggest next steps for what should come next. Now, usually if we're in a room together, I can ask people to show sort of, by a show of hands, what is this? But I don't think we really have a solid way to do that virtually. This is called the mothership. This is Richard Branson's Virgin Atlantic rocket ship that takes people into outer space. This got a lot of attention about a year and a half ago when this went live, and a lot of people looked at this and said, this is a bunch of billionaires out there having fun. What is this all about? But when you dig a little bit deeper, you find out that there's a lot of substance behind some of this work, although it's not immediately obvious. We currently pay $90 million to send one American into space on Russian aircraft, but SpaceX can do it for $55 million. And when you look at the cost per kilogram per launch, that number is going down dramatically. And so there's an enormous interest in moving that forward. And so you begin to ask yourself, maybe this is actually innovative after all, which brings up the subject of what it really means to be, in quotes, innovative. Innovative things need to be new, but not all new things are innovative. And I think that quote is important. There are lots of things that are new, right? Like a new cell phone. I've got one right here, but it looks just like the one next to it, so it's not particularly unique. You can have an invention, which is something unique and new, but not necessarily better than what exists. And innovations really refer to items which are not only invented and novel, but they're actually better than what already exists in the space. And then there's this term of disruption. And again, we can't have a show of hands, but what is disruption? Disruption really represents something that's so unique that you've generated a new market by which more people can enter and participate in the use of that particular technology. And that's important. So I think about it sort of like a funnel where there are lots of new things, fewer inventions, fewer innovations, and certainly fewer disruptions. And innovation is not easily adopted. Frankly, many times these sort of outliers to the left side of the curve here who are considered innovators have ideas that are seen as they're challenging to adopt. They're usually seen as potentially too difficult, too hard. We're going to get to some of that a little bit later. And the psychographic profile of these folks is as a technologist, and generally speaking, these innovators represent less than 2.5% of a particular group that's going to begin using this particular technology. And so once that idea has spread to some of these early adopters and visionaries, for example, you can think about any number of innovations, including your cell phone. Once you get over this chasm at about the 16% adoption mark, things really begin to advance. Those technologies begin to enter the field, and the field begins to change. And when it changes dramatically such that lots and lots of new folks can participate in the use of that technology, we call that disruption. Where, and then over time, those groups, organizations, and/or companies that have developed that technology begin to focus on those products, usually which are the most profitable. And so they have iterative innovations, which are sort of what you see this increasing blue curve here. And then new entrants enter the space with usually cheaper, more approachable technologies, which allow more folks to enter the space, generating disruption. So again, disruptors are really market creators. So how does this work? How do we say, I've got a problem, I've got an area that I'm frustrated about, and I've got a solution, and I'd like to get that to as many people as possible with something that's better than what exists? How do we do that? How do we teach people to do this? And I'm sure all of you as doctors in critical care, surgery, and beyond are thinking, man, I have 100 problems that we need to solve. So how do we do this in a way that makes sense? Well, there's really 6 steps to this. This is a little bit of a personal spin, but on a well-studied topic. And this generally begins with insight or learning. And that sounds simple, but each of you went to school for 20-something years to learn how to be a physician in a particular specialty. And that's really where this all comes from. So this turns out to be the hardest part of this process, after which we use that insight to identify an unmet need in the space that we're in. Maybe it's a ventilator system that doesn't work very well. Maybe it's a workflow that you're unhappy with, or maybe if it's an incredibly expensive piece of technology that you use every day. And so based on our insights and that need, we identify a solution. Usually the first version of that solution, which is called the minimum viable product, or an MVP, is not very good. It's not supposed to be, it doesn't need to be. But when we can test that and figure out that it actually satisfies the unmet need for which it was developed, we begin to understand what its true value might be, after which we can build, in quotes, a business model. Now, this doesn't just have to be financial, it can be operational in the context of a hospital. What are the resources that are required, and what's going to come out of this, and who is going to contribute to the process and or the financing therein. And then once we see that it works and that it's sustainable, we can begin to scale. And so that is sort of a very, very short version of what the process of innovation usually looks like. And through that, in my own experience and others, we've figured out that ideas themselves are not innovative. And I don't mean that to sound negative, but sustainable ideas are. So I get a good example. I gave a talk to some high school students just last week, and we pointed to a pair of tennis shoes, and I said, if you could make a really great pair of tennis shoes that everybody in this room would like and would want to wear, that were quite fancy and very innovative, that might be great. But if it takes $10 million to build a pair of tennis shoes that you can only sell for $55, that's not sustainable, right? And actually, we see that kind of behavior in healthcare all the time. Technology for technology without sustainability, and that's really important. And so I'm going to move now from a talk of innovation and its definition, which we will come back to reprise at the end of the talk. And we're going to talk a little bit about transplant and organ failure. Now, this is something that you guys see every day in critical care. These are sick patients. There's an incredible amount of time, effort, and work that goes into their care. But unfortunately, in the context of critical care, we see organ failure frequently, and organ failure contributes to an enormous number of deaths in the United States a year. More than 250,000 deaths from kidney failure, represented not only by this moniker here, nephritis, nephrotic syndromes, but of course those are also categorized by cardiovascular disease in some case, depending on how that cause of death is reflected. Liver disease is fifth leading cause of death in the United States and beyond. And organ failure is a problem. And transplantation, in many cases, it is the gold standard therapy, and that's exciting. But in transplant, despite this huge need for organs, we have lots of people on the list and effectively a stagnant number of organ donors. Now, I think a lot of you have seen that slide before, but let me now sort of reshape it. That slide is based on the access of organs informing the number of people on the list. This is the reality. So the number of people that we transplant every year with a kidney is about 21, 25,000, depending on the year. That does go up a little bit, about 4% each year. There are about 90,000 people or 100,000 people listed for a kidney transplant. Think about that. But 1 in 7 Americans has kidney dysfunction. And if only 5 or 10% of those need a kidney transplant, you can do the quick math to realize that 90,000 doesn't even come close. We think about 1.5 million. This is 1/2 of a conservative estimate. Some people think it's more like 3 million people need a transplant, certainly well beyond kidneys into hearts, liver, lungs, and certainly pancreas. And so when I was an eager beaver new faculty member at the University of Maryland working with Evan, I was challenged with how do we improve access to our patient population and increase the surgical volume of kidney and pancreas transplants at the institution. And so as I reflected on the trends in the industry, which were such that, believe it or not, over time, starting in 2001 to 2010 and beyond, the number of pancreas transplants had started to decrease. I asked myself, how do we solve that problem? Organ failure is a problem. We have transplant, it's not being adopted. How can we innovate this? How can we disrupt? How can we improve access to treatment in a way that's sustainable? And so the first thing that I did is to rally a large group of folks. We built a multidisciplinary team, and we asked ourselves quite openly, is this an operation that we want to do? The number of operations, kidney pancreas transplants, has gone down, but can we all agree that it's worse to have diabetes on dialysis than to be treated? And the answer is obviously yes. And so we had a pretty quick, a rapid understanding and group mentality around the need to increase access. And what we did is we built then an educational and new workflow protocol that allowed us to rapidly begin evaluating patients for pancreas transplants by looking at the kidney transplant list and figuring out which of those patients might also qualify for pancreas transplants. We then protocolized that in such a way that these patients were, there was some degree of automation, although at this time it was still relatively manual, around identifying what those patients might look like. We began performing those evaluations, and lo and behold, the number of pancreas transplants began going up. And it began going up quite quickly to the point where we became actually the busiest in the United States. I say that with all humility. This was a team effort of probably more than 60 people that were committed to this process. And in so doing, we actually began to increase quality as well. Quality and volume are certainly interrelated, although there is a curve there, much like the Starling curve. And as we began to do more, our group began to encounter challenges with actually moving those organs to the University of Maryland from distant sites. The amount of time that expired between explant and implant, what we call cold time, began to go up, exceeding 14 hours for shipped in organs. And that's a problem. It's a problem that began impeding access to the transplants, explaining perhaps why we've seen those trends nationally. And so as I began to get frustrated by this, again, reprising that first slide that I showed you, I asked myself, well, how does this even work? What does the process of national organ sharing really look like? And so we have organ banks called OPOs that burn the midnight oil to identify surgeons to go get organs at donor hospitals that they're affiliated with using texts and phone calls and emails. They then hire a courier, all sort of at sort of just in time, to identify this organ, bring it to a tarmac to meet these guys for a first flight, a second flight to meet these guys, for a courier to go to a different OPO. It's very, very complex. And that process, which takes more than 50 people and requires, I'm going to show you in just a second, 8 hours of coordination, generates very, very long cold ischemia times, prohibiting the ability to do a transplant. Now, keep in mind, I just showed you that the average cold ischemia time for a pancreas in our experience was more than 14 hours. The longest flight in the United States is 6. So there's a lot of additional time there that's spent on both the administration and the logistics of this, which I felt like we could improve upon. Now, is there real data to back this up? The answer is yes. 457 minutes are spent just in the acceptance of a transplanted organ at a major institution. These data come from AJT. They're published in the last year. These challenges have led to a series of federal level discussions about what are we supposed to do around organ logistics. You may have seen those both on CNN and Wall Street Journal in the last week, actually. There are more than 80 communications that are required for us to have just one organ get transplanted. And then these, of course, have to move long distances. Let's marry that with the price. If you do an organ transplant where the donor and the recipient are very near each other, that is a much less expensive endeavor than it is to move an organ. And that's perhaps not a big surprise, but we see that these costs get very significant. The cost of a transplant in the United States in 2023 for a liver, for example, was about $800,000. Kidney transplant is about $500,000. And those costs are, of course, amortized over a year, but they're more expensive when organs are moved. So based on all of that, so again, getting back to our steps of innovation, we had some insight around what it means to do transplant, a problem identified in the challenge of moving organs, and now a proposed solution. Wouldn't it be easy if? What if this doctor were to pick up her cell phone and hit the easy button where a drone lands and picks up this organ and delivers it to our friend over here at Mount Sinai in order to do that transplant successfully? That was sort of the initial thought, because then it would be cheaper, easier, and faster to get these organs done, streamlining a process, allowing more patients to get transplanted, allowing us to access more currently unrecovered organs and begin eating away at that massive disparity between donors and recipients. And so my apologies if I'm speaking quickly, but I just want to make sure that we reprise some of those initial thoughts and why we're moving in the direction of drones. I began to ask myself, is this possible? I started getting very excited, and Evan will attest, I'm sort of an excitable person. I ran down to the intellectual property office and I said, I got this idea, we're going to put organs on drones. And they sort of kicked me out and they said, oh my gosh, first of all, calm down. Second of all, we're definitely not doing that. It's crazy. It's too big. I had colleagues tell me it's going to be too hard. It's too expensive. And it can never be done. And when somebody told me that it could never be done, I was like, oh, I'm all in. I'm doing it. And so I began begging for money. We wrote a series of initial grants, which we were very fortunate to get funded, but actually not for drone work necessarily, but for around understanding data tools that would help us understand the logistics of actually moving organs. And so in that regard, we designed the first electronic system, which you can actually see here right in the middle. That's a sort of a telemetry device that tells us not only where an organ is and what pressure and environmental factors are affecting that organ, but of course, where it is and how long it's been out of the body. We then bought a drone, of course, with the money that we said we were going to spend on IT, and began doing the first series of experiments.
Here it is.
And there it is. That is me back in 2018 with a little bit more hair doing the first series of drone experiments. Very exciting. During that series of experiments, we compared the results of the telemetry devices that we used on drones with that of airplanes. We chartered an airplane for that series of experiments. And we found that there's an enormous amount of difference in, for example, vibration that affects an organ moved by plane versus by drone. Now, this is not to say that drones are somehow better than airplanes or vice versa. They're very different, but there are differences and they are currently unmeasured. And by not measuring them, it may contribute to the outcome of a transplant. We looked at pressure. This is a series of curves that help us show that when an organ goes up, there's less pressure experienced by the organ. Can you give an organ the bends? I don't know, but again, it's currently unmeasured. So with a little bit of preliminary data behind us, we then asked ourselves, could this be done? So we've done some research experiments that demonstrate that it's possible to move organs by drone, and that's exciting. But is it really possible in a true clinical form? And so to do that, we were funded by the state of Maryland's sort of version of the NIH. It's an incubator group called TEDCO to build out the first organ drones, which are shown here. Now, at the time, I was at the University of Maryland, which was 20 great years. And so you'll notice that our drone was designed in the University of Maryland colors, which is probably the most important thing about this slide. Looking back on it, it looks quite primitive, but it was quite useful. We then built out a sort of a second version of what that telemetry device would look like in a more commercializable form that could actually be used by doctors that are doing this important work. We identified that we could monitor not only the peri-organ temperature and compare that with ambient, but we began to see we had better resolution around vibration and pressure while those organs were being moved. You can see that there's a statistical difference here actually between vibration in car and drone. And so more to come on that in just a minute. We used those first then series of devices to begin a clinical trial of one patient to move an actual human organ for transplant by drone. This was done in 2019. It was a first in human experience, incredibly humbled to be able to lead that group. And frankly, that there were people willing to take that journey with me and with our laboratory. We moved that organ 3 miles, landed on the helipad of the Shock Trauma Center in Baltimore, Maryland, which did require that we defer any shock trauma admissions during that 9-minute window because the helicopters would have blown the drone off the roof. We took biopsies before and after. The kidney worked beautifully, and she's doing well today. Now, that story was intentionally sort of attention-seeking, and it made its way around the world pretty quickly. That was sort of our 10 minutes of fame. But what it said to us, and I show you this slide very intentionally, that people care about this. Guys, people care about innovating the work that you do to save lives every day. It is great to have a cool pair of shoes. It's great to have a telephone. But when you apply technology to life-saving work like you guys do in critical care units every day, people will care. So based on that experience, we asked a couple of critical questions. If this is really possible, we can monitor organs. We might be able to even overlay innovative organ shipment, for example, with drones into this space. Let's ask the community, is this a problem worth solving? Going back to those 6 steps of innovation. So we've gone from identifying a problem to a proposed solution, and now we're asking ourselves, does this potentially satisfy the need that we began with? We're sort of testing that. And 87% of the group of on-call transplant surgeons that are members of the ASTS agreed that the current infrastructure for both communicating about organs and moving organs is insufficient. We took this to, which is now funded by the NIH. We took this work to the NIH and said, look, we understand that moving organs is already a challenge and we're not collecting data around their environment. We think that a system that did that would be smart. Surgeons have agreed that that is the case. So why don't we also understand what those biophysiological parameters imply in terms of organ function? What you see here is that is a heterotopic heart transplant in a mouse across a full MHC mismatch. And we found that when we modeled the vibration of an airplane in a mouse, very difficult, by the way, we began to see that the vibrated hearts, these are vibrated before the transplant to, again, mimic an organ shipment, those died faster, those grafts failed faster than they did in the control group. But they didn't fail in 2 days. They didn't fail in 1 day. They weren't primary non-function. They weren't destroyed. They worked. But the way that they failed was by programmed cell death of apoptosis in the context of what may have been enhanced MHC expression or immunologic failure. And so we took that into the lab. We see that annexin, which really makes up the scaffolding of cells, was disrupted by the process of vibration. I think that's not hugely groundbreaking, but we do see increased evidence of apoptosis here directly in the vibrated heart tissue on the bottom, which is not present in the control heart. And so that was pretty exciting. We then tried to offset that by treating in what would be, for example, a preservation solution with anti-apoptotic agents and treated those mice in advance. Now, these mice are not long-term immunosuppressed, but what we did find is that if we blocked apoptosis, those grafts would survive longer. Now I'm going to stop talking a little bit about the biophysiological parameters and getting deep into the immunology and take this back to our underlying problem, moving organs and moving them better. Now, the last elements of that 6-step process around insight, problem identification, solution identification, testing is really around both business modeling and then, of course, launching. Now, I recognized in my laboratory that I could only help one patient by moving an organ and using this technology. How can I help all of the patients? Turns out that your lab doesn't save a lot of lives, but that commercial endeavors can. This technology was then commercialized in 2020 by a company that I'm very proud to have started called MEDIGO. That MEDIGO has gone from 2 employees to 25 over the course of that period of time. It's grown a lot. We are combining the data that we generate in the organ shipment process with understanding how to more efficiently move those organs, hopefully one day even including the use of unmanned aircraft when and if that is possible and approved, of course, by the FAA. The company has grown a lot. We are contracted with about 50% of the organ banks across the United States. Thousands of organs have moved across this platform. And what this does, it looks like this. It is now built out into a very user-friendly commercial version. You get a text message on your phone to tell you where it is. And much like Uber, you can see that little airplane right there. You can watch this organ fly across the United States to you, wherever you might be, better helping to better plan the operating room and get work done. Now we're going to take another step and we say, well, if we can do this for the organ shipment, what other aspects of the process in transplantation might be improved? And so we didn't stop, right? And much of this work we've done at MUSC, but we began asking ourselves, can we digitally transform? Can we take a previously modern process, all those elements of phone calls and challenges around where are the patients, when do they arrive, how do they get a transplant, of course, moving the organ itself and then tracking them afterwards, could that be digitally transformed? Now, digital transformation is probably an overused term. It's not just digitization, for example, of a paper form, but actually transforming a process such that it's easier than it was when it was not digitized. We then broke down the entire process of transplantation into 7 different buckets. And then we asked ourselves, what does that process look like today? And what would it look like if it were completely digitally transformed? And so we started with an organ offer, we screen an offer, we screen a recipient. We then, again, this is chronologic in stage 4, we accept the organ, we have logistics. I talked to you a little bit about MEDIGO. That's a company that we spun off from the technology that we developed there. OR scheduling and post-transplant monitoring. That's the entire process. So how could we transform that? If we did, we could make it easier, more efficient, help more patients, and potentially even get better quality. So that's what we began to bite off. Well, looking at the processes here at MUSC, which are not the most efficient in the United States, we began with process 1, again, moving chronologic left to right. We began automating the process, or I should say digitizing the process of actual organ offers. So we went from a standard, an unscripted phone call, hey, what do you think about an organ in Idaho? Are you interested? To a standardized series of data points that look like this, so that every surgeon gets exactly the same information each time. Now, the challenge with that is that it requires that a nurse literally type this into a text message, which has already been formatted, and that can be a little uncomfortable. Now, the reality is it's better for the patients and it's better for the system, and so we've adopted that, but we're actually moving already presently into a fully digitized app-based model of this, which not only allows for seamless text message-based organ offers, but actually records each of those and allows us to use that data. We're calling this MOCA, which is a mobile web-based on-call decision support tool. It's very, very exciting. The second step of that is to then take that offer and run it through an algorithm. This is one page of a multi-page algorithm that allows us to rapidly screen organs for appropriateness of transplantation. Now, this does not match that organ to a recipient, but you could see how by inputting that data within this algorithm would generate some results that the surgeon could then use to screen a recipient and accept that organ in processes 3 and 4. Again, moving left to right in the screen that I showed you earlier. And so sort of thinking back again on that 6-step innovation process, we identified a problem around the challenges of the organ acceptance process. We proposed a solution of digital transformation, and we are then building that solution, which would then get tested. Now, process 5, I've already talked about. I think of MEDIGO as existing in that one element of the process, but it's very exciting, already been commercialized. And now where we spend a lot of our time here at MUSC is talking about processes 6 and 7. So just because an organ is accepted, not because a kidney is accepted, doesn't mean it's the same as the kidney that we just transplanted. All kidneys are different. And so we are using an automated, protocolized approach to ensure that each of the kidneys that we transplant gets transplanted in the time that it, as fast as it can, given its quality. So organs that are absolutely perfect, we can accept organ cold times of up to 24 hours. I'm sorry, we can accept longer cold ischemia times, but for organs that have challenges, they need to go to the OR ASAP. So DCD kidneys or DCD liver is really no different. High KDPI and AKI kidneys, that is when the donor has an elevated creatinine, for example, those now via automated process get right into an operating room faster than others do. And that actually saves the operating room time because they understand what organ is coming and why that organ is challenged versus another organ which might not be. Now, after the organ is transplanted, those patients go on our post-transplant list. So they've now been transplanted, and we have plans to digitize that too. Quite honestly, this is where I spend the vast majority of my time these days. We have 150 FTEs that contribute to the transplant program that does 600 transplants a year. And while that might seem normal for us in healthcare, 150 people to do the job of one business is extraordinary. It is a lot of people. And we do that because a lot of these processes are not yet automated. You've heard about the Great Resignation. You've heard about all these folks leaving healthcare. This is part of the reason why. These folks are doing automatable tasks manually, and it's challenging, especially for people who are digital native and are expecting a higher level of digital interface. And so we began to ask ourselves, how much time is spent doing automatable tasks in the context of ambulatory outpatient settings, for example, looking at radiology and laboratory results. So we did a study internally and identified here at MUSC that providers, MDs, APPs, RNs on average spend 5.6 hours per week simply doing automatable results review. That is to say, looking for results that fit directly into a clinical protocol. And when we asked those folks, would it be helpful if there was a tool that did that for you under the guidance of the protocols that you and your teams have built, that there was a resounding yes. And so we did that. So we took that data, we took that learning, and we said, based on our team's understanding, we are spending a lot of time burning people out doing automatable work. What if we built some software that would screen each of the different patient charts for critical values that we know are important in the context of what we're looking for? So let me give you an example: kidney failure. So if the patient's had a transplant and we want to know if they are going to have a failed graft, based on both current protocol and expertise in the space, we found 10 or 15 variables that we thought were important. So we used each of those to not only be flagged by this new Epic-based protocol that we call it Petra as the name of the program, and it scrapes all the different charts for the variables that we care about, and then they're weighted to give us a kidney transplant risk score. And based on that score, we can focus on those patients that have challenges. Why is that important? Because right now, it would take weeks for each of our different 21 nurse coordinators to go through the 5,000 different patients that we have that have already had a transplant, but it takes this device 10 seconds. And in that same period of time, we can learn who's got problems, who doesn't. What is pretty exciting is we're using artificial intelligence based on protocols built from a retrospective analysis, to re-weight the system each time a new patient is entered, which is very, very exciting. The next step of this is actually to engage the patient directly and say, you've had a transplant and congratulations, but this number is too high. We've ordered another set of labs. Do you understand? And if you don't, give us a call. That then strikes a note. It goes into the chart, and the coordinator has left a message to focus on that patient for a particular day. What I've shared with you is the identification of a problem specifically around organ failure, and that we were trying to improve access to transplant, but we ran into challenges, and we think the reason why was a lack of appropriate tools in the context of both digital transformation and transportation, which we then tried to build tools to solve. Now, some of those we've spun off into companies, others are in earlier phases. But what struck me about this is that in the same time it took us to get an NIH grant to fund that mouse study, we had 22 employees at MEDIGO at the time, and we were in 30% of the organ banks around the country and had moved 1,000 organs with the same technology. The way that we think about research should change. The way that we think about doctoring should change. ought we not be thinking about innovation in the context of sustainable programs like some of these in whatever space you may be interested in order to begin asking and answering questions in a new way? So what if hospital systems who are financially vested, of course, in the outcome, for example, of a particular patient group, population, or such and so forth, or program, were the ones who effectively helped pick the winners, right? So if you have doctors who want to solve problems and get funding and do important research, and hospitals that say, hey, I have a whole bunch of problems, why not have the physicians that work within those hospitals solve those problems at the financial benefit of the hospital, wrap a return on investment around that, and potentially even commercialize that technology, helping other folks around the world. We discussed that in a recent JAMA article that you can read here. It's called A Venture Capital Model for Surgical Innovation at AMCs. Encourage you guys to take a look if you have the time. This slide is new. I've never presented it before. I was at a recent digital health conference and I was thinking a lot about this topic. And I asked myself, how is it that we have gotten that so many workflows are so difficult within hospitals? Now, it's interesting. I'm not going to demonize anyone in this slide, certainly not a hospital administrator or even a payer. That's not my intention. What I mean to show you is that physicians are uniquely positioned to help, and that's kind of the feeling I'd like you to leave with. In the model of care delivery, we have a doctor and a patient and the doctor is helping the patient, and they do that in the context of a hospital. This is where we need to be, where the innovation needs to occur, but that's frequently not what happens. As I suggested in that JAMA article that I showed you just a minute ago, I'm sorry, that we'd written, but that I referenced, is that a lot of the innovation is not necessarily being, a lot of the problems being solved by physicians are not necessarily relevant to the health systems in which they work. And I think that's a problem, because what happens is the hospitals, being the ones that pay, that generate expenses, are working with payers who are then paying. And the payers and the hospitals, in many senses, are building together, or hiring groups to build digital technologies and innovations in this space. So we're innovating over here, and we sort of have neglected the patient and the physician over here. Not a lot of new apps for helping you get to the OR faster, for helping you decrease OR turnover time, or get your patient transferred out of the ICU faster, right? In order to improve an outcome that is then measured in patient-centric metrics. We need more of that. And the people to do that are the physicians. And so I'll do a better job building that slide in the future. But again, it's sort of an introduction, a draft concept around how maybe we ought to be thinking about this. The need for innovation is huge. We're at the final couple of slides here, and then we can just move to questions and answers. Summarized from multiple sources, including Forbes and Ernst & Young and other important players in this space. We have a huge growing need for tech and AI. All of you suffer daily with the workflows of a hospital, which are incredibly inefficient. You can learn more about the ETFs in your retirement account, right? And you don't know anything about finance. You can learn about that faster than your patient's blood pressure in the ICU. And that's not only not right, but we have the tools to fix that stuff, but we need to be part of the discussion. Staffing solutions, remote healthcare, retail, these are where healthcare is going over the next 5 years, and making sure that we understand how the doctor and the patient fit into this so that we get the result in healthcare that we need is important, or we're going to end up with a bunch of innovations that potentially don't really move the needle. This is relevant not just to surgery. I'm a surgeon, and certainly not relevant to transplant. I certainly do that. It really is, relevant to all of us. Why? We have overextended human resources everywhere. Everybody says we need to hire more people. Well, I would push back and say, I don't know that we need more than 150 FTEs in transplant. We need more technology. We need more smart tools that help us work better, right? Care delivery is just too slow. Poor access to care is very real, with patients having a difficult time to get to us in an era where cyber risk and AI are a sort of increasing threat. And so how can we impact this? My request is that, and call to action, is that physicians need to be at the table for these healthcare decisions, right, around which our patients are affected. We need to be part of those processes that commercialize and operationalize these technologies, right? I think that's really critical. And I think we need to become educated in innovation. It is not a soft skill, it is real. And people are doing this every day and building companies that provide products to us in this space. And we ought to be part of that discussion. I was at a digital health conference of 8,000 people, okay? Digital healthcare conference. And I was one of 200 doctors, and I would introduce myself and say, hi, I'm Joe. And they say, oh my gosh, you're a transplant surgeon, you're a doctor. And I said, yeah, this is a healthcare conference. But that's frequently not who's at the table, and we need to be there too. We need to participate in this. We need to work as a team and row in one direction in order to try to get the best outcome for our patients. Now, I'm going to conclude. I couldn't do that, without mentioning not only a mentor of mine, but one who is incredibly dedicated to surgical critical care. I am not a critical care doctor, so thank you for bearing with me with perhaps non-traditional critical care discussion points. Mentors inform our future, and it is incumbent upon us to teach these skills to those who follow us. This, incidentally, is a picture of me when I was, maybe I wasn't very much cooler, but I definitely had better hair at the time, with my uncle, Dr. Tom Scalea, who is at the Shock Trauma Center in Baltimore. I'll just leave you with this. Peter Thiel, who founded PayPal, has gone on to found several multi-billion-dollar companies. And without referencing the financial success, he's had an enormous human impact by asking these critical questions in a book called 0 to 1. If you get the chance to read, you'll see this quote: what is the truth that you know that others do not? What are the parts of, what are your insights and ideas around those unmet needs that you know that others don't? Those are the little elements and the little nuggets of innovation. Those are the unmet need identifiers that you use to begin this process that can turn into a mothership and take us to outer space. Thank you guys very much for the time. I couldn't be more thankful of my own family, who has supported me during a number of the different journeys that we've shared with you today. This is my son Aston, and my daughter Arden, who are just wonderful. And of course, my wife, who lets me work late to do a bunch of this work. So thank you very much for the time. I'm going to stop sharing and offer to answer any questions as they might arise.
Well, Joe, thank you. That was definitely a great and interesting lecture. I'm happy to open this up. I see there is one question from Dr. Gadwani. I will allow him to ask. Dr. Gadwani, if you unmute, you can ask the question.
Thank you, Dr. Scalea, for just an amazing talk and an overview. And we are thankful that we have people like you driving the envelope of this much abused term disruptive innovation. And, people like Christensen have made it their career, this whole business of innovation. Now, listen to people like Gawande and other thought leaders. Gawande has a very interesting phrase. He says, we are very good at breakthrough innovation, but one of the simple things we forget about is follow-through innovation. In other words, just doing the things that we do it well, do it repeatedly, do it sustainably. So as an example, in the cardiac ICU, let's say, reducing the time from, door to needle or whatever, just putting in place all the little details, unloading from the ambulance, or even before pre-ambulance, sending the EKG and so on. So you understand what I'm saying. How are we doing on follow-through innovation?
It's a great question, Umesh. I think, and thank you for that. Thank you for listening. And let me also say, I'm not an MBA, and I don't have a master's in this, and I certainly haven't written books like Atul Gawande. Is an incredible person. There are challenges around sustainable innovation insofar as their implementation. It usually takes something relatively dramatic to get the attention of those responsible for funding in order to actually sort of move the needle. And I think there's an element of that that's very real, and I think some of it's just the society that we live in. But getting a venture capitalist to fund an iterative innovation is incredibly hard. But they are not only required, they're not only needed, they're required, right? Doing what we do well and doing it better is tough. I think technology has a big role to play here. I think it's very difficult to do a little better each day without the right tools in place. And forgive me if I don't completely and smartly answer the question, but I think it's hard to get people to do a little better filling out the paper form. It's a little hard to get by knowing that we have sort of in manual processes, we're only about 80–85% accurate. We really need some help. And I think as the workforce gets, I'm going to say younger, as we introduce more digital native folks into the space, I think we simply have a requirement, especially in healthcare. We have a digital debt of infrastructure that we need to pay before we can really get to those sort of daily improvements. Now that doesn't change. Every day we can care. Every day we can build teams. Every day we can lead. That we can do, and we should. And I think in that regard, we're actually not doing that well. We need to be leading our groups. We need to be at the table. We need to show up for those meetings with the health system that might seem boring and help implement and introduce some of these concepts. So a lot of words, perhaps in response, care deeply about it. Thank you for the question. And I think that we certainly have room to improve.
Yeah, thank you. I mean, I think that's exactly spot on, that there are so many things that we could do every day, little by little, getting better. But often we get seduced by the cooler thing. And you're absolutely right. It's very difficult to raise money for iterative steps and have people see where you could go with those interventions. Thank you.
Joe, there was an anonymous question from the group that said, at large academic hospitals, there's lots of silos, and in each silo, there are people in kind of the middle level management who are very invested in kind of keeping the status quo. How do you address these barriers, and how do you break through that?
Wow. Okay. So you can see the smirk building. In this talk, I used to have a picture of a farm with a silo. It said, and it's referring to breaking the status quo. So this is going to be a really boring answer, but but trust me, it works. Silos are generally created around concern and anxiety for a particular ownership over a specific area. But when there's better education and leadership around what others in that space are doing, even within your own institution, you can actually pretty quickly not only break the silos down, but develop sort of a matrix of leadership around whatever it is that you're attempting to do. Let's take pancreas transplant as an example. Pancreas transplant at the University of Maryland was very difficult to actually begin to grow because endocrinology, nephrology, and surgery had become completely siloed. And some of that was actually their own, it wasn't intentional by any definition, by any mention. None of those folks have a nefarious bone in their body, but the surgeons have been getting really good at surgery, and the endocrinologists have been getting really good at understanding what a Dexcom does, and the nephrologists got really good at understanding what the effect of immunosuppression on kidneys was. And so each of those is sort of focused on those areas. And so when I showed you that slide about the difference in 5-year outcome between diabetes and diabetes plus ESRD and ESRD plus diabetes, to break those silos down, we showed that graph. We got in a room together, and I led a team and a multidisciplinary effort to say, do we all believe in this? Are we aligned together in one space? Right? I mean, I guess it's possible. Some folks could have refused to come to that meeting, but this was not we're going to do transplant now. This is do we agree that this is a problem? And everybody, of course, says, yeah, it's of course a problem, right? Do we agree that these therapies are important and that they have definable groups of patients for whom and when you really ask, Toyota talks about asking the 5 whys for a root cause analysis. When you really get down to why we weren't performing more transplants, that group decided that it's because we didn't have a cohesive definition of who was a candidate and who was not. And so we drafted it. And then all of a sudden the silos began to go away, and we began to develop more of an interlaced matrix around how we could potentially expand that option. And we did, and the results were great. And in fact, it began to generate a lot of positive morale. People wanted to be on the pancreas team. Like, when does that ever happen, right? And because there was a lot of excitement and sort of team building around it, because the silos were gone. Now, we're talking about clinical medicine. That's mostly doctors, nurses, MAs, and APPs. That's not necessarily your finance team, your hospital administrators and such. But let me say, I do think that approach works really well within a hospital unit too, because there are so few physicians who are well-versed or interested or willing to spend their time on some of these, for example, simple workflow issues like Umesh was talking about. So how can we get better day-to-day? That I think if you spend some time, I think you'll be warmly received. I think people will appreciate the leadership and the enthusiasm around it. And I think if you show that you're a team player and you're willing to bend a little bit, people will be excited.
Okay, I believe Dr. Dengayesh has a question. Neha.
Hi, good afternoon. Really awesome talk. So I have a two-part question. The first is, you mentioned about educating ourselves so we can be at the table. Where do you even start as somebody who wants to innovate, who wants to learn about digital transformation and the financial aspects of this kind of transformation, so you can speak the same language with all the different players who are going to be at these tables? And then once you've done that, how do you go from good to great?
I'm just writing down some notes here. I'm going to give you some language right back on both of those. That sounds great. So where do you start? So that's a great question. Now I want to, this talk looks like it's a bunch of successes all strung together. Okay. So that's a bunch of crap. This is a bunch of failures that were punctuated by occasional success. And that's really important. So part of starting is being willing to fail in this context. And I think once you're sort of in that mindset, I'd say that there are a couple of things that you can do almost immediately. One is read and quite literally become sort of educated in that vein. And I actually think docs are really good at that and can kind of quickly begin to play ball with others in the space. There are more committees in a hospital system than we care to know about. And they are frequently desperate for clinical input. And I know that sounds crazy because these health systems have hundreds of thousands of people in some cases, but they really do want more clinical insight. And so ask to join a hospital committee, and you'll begin to see pretty quickly how you can use your own insights to change things. I think that by raising your hand and saying, I am willing to help, your name will get around very quickly, and that can be helpful. Now, commercially, you could, in theory, commercialize something and begin to learn that process independently, or you can work with there are a lot of startup companies that are looking for example, docs that want to be advisors and such, and help in the space for which you may work. And so those are just some basic, simple ideas. Good to Great is a well-read book about published really in the 90s, as I recall, sort of pre-technology, believe it or not, around how some companies became great while others sort of just clunked along. And in that book, the author talks specifically about generating flywheels and getting something started, right? And then taking that next step so that you sort of build a self-fulfilling prophecy of success. And so what is your flywheel? I think that begins with leadership, and I think that begins with building a team. Physicians are trained independently for years and years and years, and we're actually not very well trained at building teams. So going from good to great is not only identifying the unmet need of solution, testing it, and then you're sort of identifying a go forward plan, which is that operational plan, but building a team of people that will get the flywheel going so that success becomes a self-fulfilling prophecy.
Joe, that was so great. Thank you so much. Does anyone else have any last questions before we let Dr. Scalea go? Okay, well then I will end it. Thank you so much, Dr. Scalea. It was great to catch up with you, and hopefully we'll get to catch up again soon.
Love it. That sounds great. Thank you guys very much.